Okay, it is 7 o'clock on the dot. Welcome everyone to our first virtual CE of the year from RCTX. Welcome to everyone logging in. So excited to have all of you. For those of you who don't know me, my name is Dr. Amy Scheffler. I am an ocular oncologist. I take care of patients with cancer of the eye, as well as a vitreoretinal surgeon. I've been here at RCTX for 13 years. I moved here 13 long years ago, and it's been a wonderful journey here in Houston. I know many of you have come to our webinars before, and perhaps some of mine. Hopefully this will be fresh and new and interesting and different from some of the other ones. And always a good chance also to refresh your memory on all the weird material that I cover. So we're going to go ahead and get started since we've got lots of people on already, I think. So first, some housekeeping. So we appreciate you joining us. Of course, we want to make sure you get therapeutic credit, and you'll get 1 hour of credit submitted to the TOB for this Zoom. If you want to log on to other ones, we'd be thrilled to have you throughout the year. If you want to see the dates that will be hosting CEs, you can scan this QR code now with your phone, or you can email our marketing team at marketing@retinaconsultantstexas.com. And that'll have the list of all of our dates for the year, and we'll actually be adding some more as the year goes by, so don't forget to check back over time. So this is our group. For those of you who don't know us, we've become a big group over time. We specialize purely in the retina and related subspecialties, so retina, uveitis, inherited retinal disease, ocular oncology, medical retina, surgical retina, and so forth. We don't do any glaucoma or refraction or general ophthalmology or cataract surgery or anything else other than retina. We have the largest retina research center in the entire United States, RCA Research, which we've expanded over the last several years to include centers all across the entire United States. We have 26 physicians and 23 locations throughout both Houston and San Antonio. And on this next slide, we've got updates from our practice. So these are our 14 locations in the Houston area. Most of these have been pretty stable for the last few years with some minor location changes that I'm going to talk about in just a moment. But we're inside the loop in Bel Air, and then outside the 610 loop in Memorial, in Cypress, in Katy, in Sugarland, in Pearland, in Space Center, in Kingwood, and in 1960. And then outside the Beltway in the Woodlands and Brenham and Beaumont and Livingston and Lufkin. So we stretch really pretty much everywhere around this entire metro area. We've got two exciting moves that we want to announce. One is that our 1960 location is moving to Vintage Park. The address is listed here. We'll be there starting in August. Our 1960 office is one of our oldest ones, so really excited to update that and give it a whole new fresh look. And it's not too far away for our patients who are used to going to that office. And our Livingston office moved over just, I think, one suite in the same building, different suite number, but same general location, to a new and fresh and improved location for our East Texas patients. Our San Antonio team sees patients at 9 locations throughout the greater San Antonio area, all listed here, including a central medical center office as well as a research office. And I think some of these offices are actually relatively new, so definitely reach out to our docs there if you've got a colleague in San Antonio who wants to refer over a patient with a retinal issue. So if you want to contact us with a patient, this is how you can reach us. There's many different ways to get to us. You can call our provider line, which is listed here. Certainly take a picture of the screen if you can. There's one option for Houston and one option for San Antonio. Of course, 24/7, we always have a physician on call if you have a patient with an emergency or an urgency on the weekend. I know many of you see patients on Saturdays. You can also refer a patient online, and the web address is listed here, or you can fax in a referral at one of our fax numbers. And any way that you choose, the patient will be scheduled quickly. So you can follow us on all of our social media. The QR codes are listed here. Lots of information is posted on these sites, including updates about when we develop new locations or we hire new doctors, announcements about our CEs like today, lots of blogs about brand new drugs when they come out that we'll be using and new treatments, fun initiatives at our practice for our staff and our patients, patient testimonials, amazing videos that our video team creates to educate patients and staff and the community about retinal disease and more. So definitely, we have an amazing social team. So definitely check it out when you get a chance. And of course, our website, retinaconsultantstexas.com. Okay, so just make sure, again, once more, that you get your CE credit. Here's the Zoom for that. And if you have any issues getting your credit, just email our marketing team so they can make sure that you get the credit. All right, so now I'll move on to the meat of the lecture. I'm going to be taking questions at any time. The way this webinar is set up, you can't raise your hand, but you can ask a question on the chat, and one of my colleagues who's on is going to kind of alert me when there's a chat from one of y'all, and I'll be happy to stop. You can interrupt me anytime and address any questions that you have. It's meant to be interactive and fun, so feel free to throw out any crazy questions. So this is just a kind of a nice collage slide I always like to show at the beginning of my general tumor lectures, just to give you guys a sense of kind of the craziness of what I do. This is sort of a day in my life. There's very little kind of boring stuff in my clinic, so kind of crazy looking, colorful stuff at the front and back of the eye. So tumors are kind of their own world, and they bring both challenges and interesting questions. So my plan for today's lecture is I'm going to give you kind of a feel for some both common and rare things that we see, and how to kind of think about lumps and bumps in the eye when you see them in your clinic. So broadly speaking, how to think about elevated lesions or unusual colored lesions when you see them, when you're seeing patients, is in terms of categorizing them, is first of all, how old is the patient? Has this lesion ever changed over the time that you've been following the patient? How many of the lesions are there? How many do you see? And perhaps most importantly, what layer of the retina, vitreous, choroid, or sclera is the lesion in, and what color is it? And in particular, in this lecture, I'm going to focus on those last two questions, because those are the easiest to think about in terms of the imaging that you all get in your clinics and the imaging that we get when you send the patients over to us for further evaluation. So of course, everybody these days pretty much will have an OCT in their clinic, and we all think about the anatomy of the retina kind of through this image that's kind of burned into all of our brains of the retina. And this is a good way to think about tumor pathology in the retina and in the choroid and in the sclera in terms of what layer the pathology arises in. So of course, the innermost layer is the ILM, or the internal limiting membrane. And then moving from inside to outside after that, we have the nerve fiber layer, the ganglion cell layer, the inner plexiform layer, the inner nuclear layer, the outer plexiform layer, the outer nuclear layer, the external limiting membrane, the iSOS junction, the photoreceptors, the RPE, and then within the choroid, Brooks membrane, the choriocapillaris, the choroid, and the suprachoroidal space, and then the sclera. Each of these layers, kind of presents itself with a certain particular appearance in the normal anatomy, of course, but then also with particular patterns when there's pathology of any kind occurring in those layers. And I think this is a good structural way to think about the diseases that you'll see that are relevant in this talk. So tumors can occur in really pretty much almost any of the layers that I mentioned, which is kind of in and of itself a fascinating thing about ocular biology. And here we have listed all the different things that can happen in the different layers of the posterior pole. So you can have tumors that present in the vitreous. You can have tumors that present in all different layers of the retina, some of which are malignant, some of which are vascular, some of which are completely benign. You can have tumors that present in the deepest layers of the retina, like the RPE. And then you can have all sorts of some both benign and very aggressive tumors that can travel to or present in the choroid and also in the sclera. So we kind of think about these inside to outside, and we'll go through these one by one as we go through the lecture. So the other parameter, as I mentioned in the beginning, to think about is color, because that's, of course, certainly a very easy thing to think about whenever you're looking at the back of the eye and taking pictures of patients. So we're going to start by thinking about lesions that are kind of in the white, yellow, gray, orange spectrum. And then we're going to finish up by talking about more darkly pigmented, brownish, blackish lesions, because I think this is kind of an easy way to divide them. So here's just a quick example of 6 kind of orangish, yellowish lesions, and we'll cover all these one by one. So we're going to start with the inside of the retina and then move posteriorly. So let's say this patient walks into your office and you take a picture and the patient is asymptomatic. One thing about this lesion that is not going to be true for most of the things that we talk about today is you can see that the pathology is actually obscuring the blood vessels in the retina. We can tell that it's in the retina because it's flat, it's not poking into the vitreous, but it is obscuring the blood vessels. And then it helps you understand that this particular pathology is very superficial in the retina, right? It's fluffy looking, it doesn't have well-defined borders, and it's around the optic nerve. Here's an OCT through this same lesion. You can see that this pathology arises from the innermost layer of the retina, from the nerve fiber layer, and it's kind of this glossy, kind of longitudinally shaped lesion that obscures the inner portion of the retina. And I'm trying to see if I can open the chat. Anybody is welcome to call it out in the chat if they figure it out before I get to it. But this is called a myelinated nerve fiber layer. So this is a congenital, primarily abnormality. It can rarely be acquired. And essentially what it is nerve fiber cells that have myelin on them, a covering that occurs in nerve cells that are present in the central nervous system. During normal ocular development, embryologic development, that myelin actually retracts from within the eye and goes external to the eye. So when we see it, it's actually an abnormality that it didn't retract as much as normal. And generally that lack of retraction occurs in the end of gestation, 8th and 9th month of gestation. Typically, it'll obscure the retinal blood vessels, although it can both be in front of and behind the major vessels, as you saw in that picture. And it's usually completely asymptomatic with no visual sequelae. Sometimes if it's extremely extensive and involves the entire macula, it can affect patients' vision. And it's benign and requires no treatment at all. So moving along, thinking about other lesions that are also in the white yellow color spectrum and are in the superficial retina. Here's another lesion, and I put this one after the myelinated fiber layer on purpose because it's kind of similar looking and kind of confusing, right? This is also a white kind of feathery looking lesion that's very superficial, also obscuring the retinal blood vessel. And when you look at the EDI-OCT cross-sectionally through it, you can see that this is also in the superficial and mid layers of the retina, obscuring the deeper retinal layers, quite hyperreflective on the OCT. But what's different about this versus the other lesion is that it's elevated and it's round, and you can see it's really kind of jutting into the vitreous in a more three-dimensional way than the prior picture that I showed you. And this is a tumor called a P-scrap. P-scrap is the first lesion I'm talking about tonight that we can see either in isolation or in the context of a really complicated genetic multi-system syndrome, which is common for a lot of tumors that we see in the retina. So this is an acronym. It stands for Presumed Solitary Circumscribed Retinal Astrocytic Proliferation. That's kind of a mouthful. But essentially what that means is a benign tumor of the astrocytes, which are kind of connective tissue cells within the retina that are solitary typically and benign and not associated with any systemic disease. Now, sometimes we'll see a patient with many of these associated with a genetic condition called tuberous sclerosis, which can be associated with a lot of other systemic problems, including neurologic problems. But when it's seen in isolation in an adult, it's typically solitary like this, oftentimes peripapillary and fluffy and white and in the inner layers of the retina, just like the one that I showed you. So those are two of the things that you want to think about when you see a white fluffy lesion in an adult near the optic nerve that's obscuring the retinal blood vessels. So let's talk about other things that are kind of whitish, yellowish that can occur within the retinal layers. This one a little more dramatic than the two that I showed you. Here's a 25-year-old man I saw several years ago who came to from Louisiana for like his fourth or fifth opinion after seeing many retina specialists with decreased vision in this eye to about 2100. He had this large, very vascular lesion within the retina. You can see this one is not in the very superficial layers of the retina, but in the deeper layers of the retina as the retinal blood vessels are kind of coursing over it. And it's highly vascular and highly exudative, right? We see lots of subretinal fluid, lots of exudate in this kind of succinate pattern, which is leaking to the macula and obviously causing his decreased vision. Kind of scary for something like a melanoma, but typically melanomas don't have this much exudation and they have a very different look on both OCT and other diagnostic testing. And when we do this OCT right through the lesion, what you can see is that it arises from within the retina, right? Not from the choroid in the deeper layers. So we can see that this is in the mid layers of the retina, obviously, pushing the retina up, causing lots of subretinal fluid and exudation. And this is, and we see on the ultrasound that it has kind of variable echoic signal, kind of a little hyperechoic, a little hypoechoic, which is typical for this. And we can also see on the ultrasound that it's arising from the retina, not from the choroid, which helps reassure us that it's not something more malignant. So this is called a retinal capillary hemangioblastoma. Similar to the last pictures that I showed you, this is something that can occur in the context of a bad systemic genetic syndrome, or it can just occur sporadically. In the case of this gentleman, it was just a sporadic lesion. It can cause a lot of vision loss from exudation, subretinal fluid, cholesterol crystals, as you saw in that picture, and it's mostly in younger patients whose vascular supplies are very robust. Unlike some of the other things that I showed you so far, these tumors actually can respond very well to a combination of photodynamic therapy, laser, and anti-VEGF, as long as it's performed in a very specific sequence. And this is a long-term outcome picture of that same picture I showed you, that dramatic picture from the start of that same 45-year-old gentleman. About 5 years later, he's got 20/25 vision in this eye, maintained with anti-VEGF injections, doing extremely well. So each of these tumors has its own natural history and its own underlying biological causes. Some of them are amenable to treatment, some of them are not, but this is one that that certainly can be, as long as we're able to recognize it.
Hey, Amy, we had a great question. I'm sorry to interrupt you real fast
Great.
from Dr. Harper. I actually had the same question, so I'm really anxious to hear the answer. How are these different from astrocytic hamartomas that we all learned
Okay,
about
perfect.
way back when?
Yeah, yeah, great question. Okay, sorry, it's hard to monitor the chat while I'm talking. Great question. So the P-scrap lesions, the ones that I showed, let's see if I can go back. These lesions, just so that's really clear. These lesions are pathologically identical to astrocytic hamartomas, but they occur not in the setting of tuberous sclerosis and other genetic diseases in which astrocytic hamartomas are known to be part of the syndrome. So you can think of it as a synonym. It's the same thing, but they occur spontaneously. And the genetics of them are not as well understood as they are in the case of tuberous sclerosis. So those are, those lesions are effectively the same. Retinal capillary hemangioblastomas are completely different. They don't arise from astrocytes. They're thought to arise from actually the endothelial cells within retinal blood vessels. They're much more exudative. And when they occur in a systemic context, they occur typically in the context of von Hippel-Lindau disease, another systemic disease, which I was about to show you guys right here, which is also an autosomal dominant genetic disease in which patients can have multiple of these. And this is a patient I saw just last week who's about 36 years old, who had, many of these lesions, some of which you can see have been treated by lasers, some of which are untreated and partially active. And this lesion also arises from kind of the mid layers of the retina and kind of elevates the retina. And in this case, this lesion actually has the hyaloid attached to it. Does that answer the question, Dr. Harper and Dr. Pierce?
Absolutely. Thank you.
Terrific. Oh yeah, thanks. Thanks for bringing it to my attention. Well, all right. So that covers the kind of superficial and mid-level retinal lesions that I wanted to talk about today. Worth noting that the most scary malignant lesion that arises from the retina, of course, is retinoblastoma, which occurs in children. And I'm going to get to that at the end if we've got time. But because we're going to focus on adults for the majority of the evening tonight, I wanted to kind of keep moving along to the important lesions that we see in adults in the choroid. And you see a list of those lesions here. This is not an exhaustive list. There are certainly other things, but for the sake of time, I'm going to focus on these. And these range from things that are totally benign to very scary and very malignant, and we'll go through them. So when we think about choroidal lesions, it's important to think about the pathology of the choroid. So the choroid, of course, is the vascular layer that supplies the blood supply to the majority of the retina. And it's an extremely vascular area of the human body, arguably has one of the richest blood supplies, vascular networks in the whole entire body. So superficially up here at the top of the slide are the photoreceptors in the retina. And then just below that, superficially, is what's called the choriocapillaris, which is a very important part of the choroid that plays a role in many of the retinal diseases as we understand them today. Then we have sort of the medium vessel layer, which is called Sattler's layer. And then we have the very large vessel layer, you can see here, lined by an endothelium, a very rich endothelium, and then the suprachoroidal space, and then finally the sclera. What you see looking at the slide, even if you're not a pathologist, is that first of all, there's many, red blood cells here and many blood vessels. Again, it's a very rich blood supply. And also there are melanocytes in this layer. So there's all these scattered brown cells which migrate to this location actually during fetal development. I'll get into that later. But essentially, the way to think about this is that tumors that arise in this layer arise here either because they come from these melanocytes or because they travel to this space via these very juicy blood vessels that connect with the rest of the hematologic system in our bodies in a very robust way. So we'll start with some benign, not as scary things. Here's a 72-year-old asymptomatic woman who, came to me being sent in by a retina specialist for a tumor. And one thing that, kind of should jump out you when you look at this picture is like, well, gee, I don't really see much of a tumor at all. This looks like a pretty, normal fundus photograph. But when we do an EDICT over this area right here above the optic nerve, what you see is this very vascular sort of juicy mass that is compressing the sort of inner layers of the choroid in this axial way and is definitely not arising from the sclera, but from within the choroid. But rather than disrupting the anatomy of the choroid, it's just expanding axially. And you can also see that the surface of the lesion is very, very smooth and the inner layers of the retina are not disrupted at all. And that's very typical for this lesion. So we've got something with a solid surface, smooth surface, axial compression of the choroid, blending into the normal surrounding choroid. On the ultrasound, it's very what we call echographically solid. It's not hollow, it's not dark, it's not hypoechoic or dark, it's solid and bright. And that typically means it's something that's much more benign rather than aggressive. And here's an example of another one of these. I put this up here to show that, as we all know, one of the challenges with Optos photography, particularly with the older models of the software, the RG software rather than the RGB software, is that can really distort color, which is a challenge with tumors. So it looks a little bit brown here, right? But this is actually more reddish orange in real life. Similar looking ultrasound, echographically solid. And in the case of this patient, subretinal fluid leaking into the macula, causing vision loss. And here's a scan right through this lesion. In this case, also smooth, but with some RPE atrophy, probably reflecting, kind of chronic change. So this is what's called a choroidal hemangioma. This is a benign tumor, reasonably common tumor of the vascular tract. It typically presents in patients who are in about the 20 to 40 year age range. It can present in much older patients, and when it does, there's often other changes that occur that make it look different, but typically, most commonly presents in the 20s to 40s. Much more often in the macula, thought to be because it's, as a result of overgrowth of blood vessels, and that blood vessel network is the richest and the most predominant in the posterior pole. So the vast majority of these do occur posterior to the equator and really primarily within a very small area of the fovea. These can occur, like many of the lesions we've talked about, in either circumscribed or diffuse form. The diffuse form often happens in the context of genetic syndromes, such as Sturge-Weber, and the circumscribed form, just one lesion, kind of sporadically in adults. These patients we typically will treat only if they are symptomatic from subretinal fluid, as per the picture that I showed. Patients whose vision is dropping because that fluid is causing vision loss and damage to their photoreceptors, and photodynamic therapy is extremely effective for getting that fluid to dry up. So any questions about hemangiomas before I move on?
So I've got a question, and maybe some others will find this
Sure.
interesting. Occasionally, I
Sure.
feel like maybe once or twice I've seen these with a really exuberant subretinal fluid response. Maybe it looks like a retinal detachment. How effective is PDT in those cases, or how would you approach that case?
Right. Great question. So, I mean, the amount of subretinal fluid, the extent of it, how chronic it is, how much damage it causes to the RPE and the photoreceptors is really dependent on how chronic it is. They all start out with a small amount of fluid, and then if they're left alone for too long, and particularly in young patients with a very robust degree of choroidal flow. They can leak a lot. And some of those patients can really have long-term visual damage. The PDT is most effective the newer, the kind of least amount of time the fluid's been sitting there. And that's kind of similar to other retinal diseases, right? The longer the fluid sits there, the more damage there is to the underlying photoreceptors and RPE. So we try to get to them as soon as we can, even in chronic cases. Sometimes I'll see patients who, clearly have had fluid for several years or even a decade. We'll still try, but give patients the caveat that, hey, look, this may not be able to dry up this fluid. And even if we do dry up the fluid, the amount of photoreceptor atrophy that's there because of its chronicity may inhibit visual recovery. And we try to be very honest with patients about that. But we don't really use chronicity as a kind of an inhibitor for trying therapy, because I certainly have seen, recovery even in reasonably chronic cases. One of the very interesting things about choroidal hemangiomas is that we published about 10 years ago, and some other centers followed, that actually the underlying anatomic predisposition for choroidal hemangiomas is a pachychoroid state. So pachychoroid are patients who have kind of a much thicker and juicier choroid than average. The most kind of common disease that I think probably everyone on this Zoom deals with, in which a pachychoroid is a predisposing factor, is CSR or CSCR, central serous, in which patients are just anatomically have a particularly thick choroid and are anatomically predisposed to those little pockets of subretinal fluid that you see that can, and sometimes neurosensory fluid that can cause a vision loss. And it actually turns out choroidal hemangiomas are also caused by that same anatomic predisposition. And if you look really carefully in the fellow eye of many patients who have choroidal hemangiomas, they will have subtle signs of central serous. So we think about it in that context, and the more pachychoroid the patient is, the more they're going to leak and kind of the more fluid they're going to have. So that may account for some of the differences you see in the degree of fluid that patients have when they present with this. All right, so on to our next entity. This is a 50-year-old female who presented to me with blurry vision down to 20/40. And you can see that this lesion is also kind of orangey red, like the choroidal hemangioma that I showed before, but it's more visible certainly on the fundus photograph than the last one, right? It doesn't exactly blend into the surrounding choroid as much. And it has this sort of very sharply demarcated border and more of a kind of a bright orange color rather than a deep orange compared to the hemangioma. And what's interesting about the EDI OCT in this patient is that you see these kind of linear configurations within the choroid, these sort of hyper-reflective dots within the choroid, and these linear configurations that are actually pretty pathognomonic. Here's an example of another patient with a very similar lesion, also kind of highlighting these kind of linear striations kind of within the choroid. Also a kind of relatively young female patient, which is typical for this. When we do the OCT for many of these patients, we also see subretinal fluid similar to those hemangiomas. These lesions leak for a different reason, which I'll get to in a moment, but similar to choroidal hemangiomas, these patients often present because they've got vision loss from fluid. And when we do the ultrasound of these patients, it's truly pathognomonic. Here's the front of the eye right here. Here's the back of the eye. And what you see with this lesion, unlike that elevated choroidal hemangioma I showed, is that it's very flat and it's very, very hyperechoic, meaning the sound waves come in from the ultrasound probe come in, they bounce right off the lesion and right back. And really only one thing in the eye is quite this hyperechoic, causing this much shadowing, and that's calcium. We see that in the context of any tumor that has calcium in it. And so this is called a choroidal osteoma. This patient underwent actually a series of anti-VEGF injections. Here she is 7 years later. I still follow this patient, and her vision is an amazing 20/20. These patients can, in many cases, be extremely responsive to anti-VEGF therapy. So these are benign. It's caused by ossification of the choroid. Interestingly, they happen mostly in young women. We don't know exactly why. They are often peripapillary or occur in the macula. They can be bilateral. And when they are, we typically will do a workup for understanding any reason why that patient might have hypercalcemia and be particularly at risk for calcium depositing in the choroid. And the thing about these lesions, which is interesting, that they can actually develop decalcification on their surface. And that is typically when patients start losing vision, either because it causes retinal pigment epithelial loss or because patients develop choroidal neovascular membranes, which can leak. The CNVMs in particular are very responsive to injections, the decalcification not as much. And so, we do fluorescein angiography and B scans and OCT and all of these other pictures and images that I'm showing you to help understand, why is this patient leaking? How long has it been going on? How chronic is this, to kind of give us patients a sense of, what their visual potential is. But these are completely benign lesions, and luckily don't metastasize ever or transform into anything malignant. And so kind of one of these happy stories where we can tell patients that they're going to be okay. So moving down into the sclera, we're going to talk about a couple other kind of yellowish, brownish, yellowish, grayish lesions that are in the sclera and in the choroid before we get to some of the scarier, more malignant lesions. Here's a 79-year-old asymptomatic male sent to me for rule-out melanoma. We've got this kind of scalloped yellowy orange lesion here in the supranasal quadrant. You can see this patient has kind of some age-related mid-peripheral drusen and even some kind of very subtle choroidal folds. Same exact thing in the other eye, in this case, kind of a little more supratemporal or superior. When we do the ultrasound, interestingly, this lesion looks kind of similar to that choroidal osteoma I showed you, right? It's very hyperechoic, it's causing lots of shadowing, but it's a little more thickened and elevated, and that's pretty typical for this. Here's the EDI OCT for this patient. This is very, very pathognomonic for this entity. It has kind of like what we call a tabletop shape, and you can kind of appreciate that the choroid here is very thin and compressed. This is an older patient, so we expect the choroid to be thinner because the choroid becomes atrophic with age. But the lesion is really evolving mostly in the sclera and pushing into the choroid and compressing, and it has this kind of, again, kind of squarish configuration. And that's very classic for this. There's another patient with this I saw last week, sent to me by another retina specialist, similar lesion, supratemporal quadrant in each eye, kind of this scalloped appearance, very hyperechoic on the ultrasound, tabletop configuration on the OCT pushing in from the sclera. And this is called sclerochoroidal calcification. Now, as I often tell patients, the good news is you don't have cancer. The bad news is you're not getting any younger. This is typically an age-related lesion, as are many things that we see in the retina. It occurs mostly in patients over 70. It's often symmetric or slightly asymmetric, but bilateral. It's usually supratemporal. Patients are almost always asymptomatic. There's absolutely no need for intervention. They can slowly enlarge with time, but they never cause vision loss, or almost never cause vision loss. And they are typically not associated with systemic conditions. In very rare cases, they can also be associated with hypercalcemia, but almost never, particularly in older patients. So kind of another one of these good stories that we get to tell patients when they're worried that they might have something more malignant. Switching gears to something that we see in younger patients, here's a 40-year-old male that I saw just a couple weeks ago with distortion in the left eye, also sent in for rule-out melanoma. This lesion you can see is kind of yellowish, orangish, grayish right in the macula. Clearly, you can see that it's elevated, right? Because the retinal blood vessel kind of changes direction as it hits the apex of lesion, kind of like a car driving up a hill, and that's a sign it's elevated. So we get an EDI OCT through it, and you can see, just like the last pathology I showed you, that this is a scleral-based lesion, right? It's kind of jutting into the inner layers of the eye, compressing the choroid here into this teeny thin layer, and then causing lots of RP atrophy over it, and even some passive intraretinal fluid, all as a result of inflammation from the lesion itself in the deeper layers. Here's another patient I showed just last week with the same entity, same deal, kind of orangey yellow, fairly circumscribed, a little bit blurry margins. It's a scleral-based lesion pushing into the choroid and creating this this kind of compression of the choroid and RPE changes. And this is a lesion called solitary idiopathic choroiditis. Of all of the lesions that I treat, I think this is probably the absolute biggest misnomer, and one of the things that my colleagues and I around the country are always discussing and arguing about, and talking about how should we rename this? How should we make it more clear in the literature so that other ophthalmologists and eye care providers can understand it? So this is really not not in the choroid. It's not inflammatory, as most things that are called itis are. It's really more of a solitary scleral nodule, and there's kind of a big move in the field to change the name to that. But in any case, it's unilateral, it's orange-yellow, it's circular, and it's typically in the posterior pole or just outside the arcades. It's usually younger patients, 20s to 40s, slightly more common in men. It rarely can be associated with autoimmune or infectious conditions such as sarcoid or TB. And in some cases, I will do lab work if there are there's other suspicion for these conditions. But unless the patient has CME or subretinal fluid affecting their vision, we typically do not intervene, and the majority of patients do not have any of those problems. But because those lesions are elevated, they can look kind of scary. So we're always happy to look at them. All right, so moving along to kind of the browner, darker lesions, some of which are kind of the scariest things that we see. Just looking quickly to see if there's any questions that I'm missing. Will, you got anything that I'm not seeing on the chat?
All good.
All right. Okay. So here's a kind of a smorgasbord of pigmented, scary lesions that I see in the eye. These, of course, can often cause panic in all eye care providers, including even retina specialists. So if you see one of these things in your clinic, um, feel free to panic. It's a normal response, and go ahead and give me a call anytime. Some of these things are dangerous and worrisome. And so I always tell my patients, I never ever criticize a referring provider for over referrals, really only for under referrals, because I think that's kind of the only way to keep patients safe. And dark lesions can be among the scariest things we see. So it's not crazy to send these patients at all. So when you think about pigmented lesions in the eye, they really basically can come from two places, right? They can come from the RPE, right, which is of course, has melanin in it and is darkly pigmented, or they can come from the choroid, from those melanocytes that I mentioned that are present in that layer. And so whenever you're seeing something dark, typically the origin of it is from one of those two layers, and that's the way to think about it. So we'll start with this relatively unusual but very cool looking lesion. Here's a 45-year-old asymptomatic African-American male sent in to me for rule out melanoma. The patient's got this kind of large, juicy looking round lesion kind of infringing from the peripapillary choroid onto the optic nerve. And here's kind of another patient with like almost like a smaller mini version of this and a little EDI OCT through that lesion that shows these little kind of hyperreflective granules that kind of from a lesion that starts in the choroid and then kind of elevates up into the inner layers of the retina, and that's pretty typical. Here's a lady I saw literally just Friday with this same entity, same exact type of lesion, 28-year-old Hispanic patient, totally asymptomatic, absolutely no symptoms, with this kind of brown, round, elevated tumor infringing on her optic nerve. Here's the EDI for that patient. It's even more elevated, so it's kind of going off the screen on the EDI, but you can see there's these typical hyperpigmented granules. And on the ultrasound, it's kind of mostly hyperechoic, and we can see that it's kind of going into the retina and kind of elevating the inner layers of the retina, which is pretty typical. So the tip-off in this case, besides the imaging characteristics and all of the subtleties of the diagnostics, is that these patients are both darkly pigmented, and that's something that should always kind of raise a kind of a red flag or a bell in your head. So this is called a melanocytoma. Melanomas, malignant uveal melanomas, are extremely uncommon in African American patients, and they are relatively uncommon in Hispanic patients, not unheard of, but relatively uncommon. So it is much more often the case that darkly pigmented patients have melanocytomas, and that's a good news. That's good news for this population because these are benign lesions. They are often peripapillary, although not universally. The pathologic name for it is a magnocellular nevus. When we dissect these on pathology, the cells are particularly over large and oversized, and they're typically hexagonal, which is why they're called magnocellular. They are typically a dark black or jet black color. And most of the time, they enlarge very slowly over many, many years and don't cause a problem. The few problematic things they can do is cause retinal vein occlusions if they crowd the optic nerve too much, cause glaucoma if they cause optic nerve swelling, as you can see a little bit in this patient, and they can cause field cuts if they just obscure one portion of the optic nerve of the retinal nerve fiber layer. And very, very rarely they can cause malignant transformation, but it's really like 1% of the time. Of course, because I see the craziest stuff out there. Here's a 74-year-old Hispanic man that I saw last year who was totally asymptomatic. He was followed by a retina specialist who, because he thought it was a melanocytoma, was like, oh, this is benign, I can kind of just follow it. He was followed for 5 years, but then he was lost to follow-up. And in that time, the lesion grew both laterally as well as in height, and then obscured the entire optic nerve and actually became, quite vascular and quite large. Here's the ultrasound of that lesion. And you can see that it is similar to the ultrasound I showed you of that other benign lesion, but it's quite large, extending over the entire optic nerve head and starting to invade into the optic nerve. And so this was an example of a melanocytoma that had transformed into a melanoma. One of my residents wrote this up and published it. We did enucleation of this patient's eye because it wasn't able to be treated by more conservative measures. And these are just cool pathologic slides seeing what these look like once the eye is removed. Here's that collar button shaped lesion kind of jutting into the vitreous and then into the deeper layers of the optic nerve head. Here's a cross section of it. This is the optic nerve. And you can see these brown tumor cells invading into the optic nerve, which is atypical for a melanoma and really would only occur, in this type of setting where you have a melanoma melanoma that transformed. Here are those, what I was telling you about before, these magnocellular cells, these oversized hexagonal cells with this like very dark, dense pigment that we see on these. And then our pathologist uses all these special stains called HMB45 and Ki67 to kind of mark which of these cells are undergoing mitosis, dividing, and are identified as melanoma cells so that, she can see, okay, yeah, there's been malignant transformation. These are melanoma cells and so forth. And so we were one of the first to publish on the modern genetics of these and understand them. So very rarely, like this case, these can become malignant. And so I do recommend that you send them over. But the vast majority of the time, these patients are actually completely fine. So here's a 15-year-old asymptomatic female who was sent to me for real melanoma. I think I saw this patient, just a couple of weeks ago. And I see many patients with this entity often, I would say, because oftentimes these lesions are picked up in young kids. We can see that this is a very sharply demarcated area and that there's kind of almost like a ring of dark without pressure around it. These come in all different sizes and configurations, and I'll show you some examples. Here's a beautiful OCT through it by our photographer, one of our photographers who's very talented at getting beautiful OCTs even through peripheral lesions. What you can see in the area of this lesion is that the inner layers of the retina are actually reasonably intact, but it's actually the RPE that is kind of all mottled and irregular and atrophic, and that's pretty typical for this. Here's a 22-year-old. Similar looking lesion, kind of scalloped borders. One of the very typical things about this is that you could almost take a pencil, like a really thin line, and draw a demarcation line around the edge, which is very, very classic for this. Same thing, beautiful OCT through this, and you can basically see that the inner layers of the retina are completely normal right until you get to the beginning of the lesion. And in the area of the lesion, the RPE is basically completely absent. And so the primary abnormality here is in the RPE. Here's another example, 11-year-old girl with a couple of adjacent satellite lesions, which is also not uncommon. And here's another OCT through another one, just showing that abnormal RPE. And these can be present primarily in the periphery. You can also see them peripapillary, or even, as in this case, in the macula in an older patient with a PVD, but most of the time they're in the periphery. And so this is called a chirpy. I know many of you have seen these in your clinics and probably seen our handouts about these that I give to many, many patients each week. This is a congenital lesion, meaning it's present at birth universally. It is commonly peripheral, as I mentioned. If you do formal visual field testing of these patients, they do have a relative scotoma in this area of this lesion, because when that RPE does not develop normally in embryologic development, typically the overlying retina is also not normal. So for the rare patients who develop these in the peripapillary area or in the macula, typically their vision is not normal. And these are completely non-cancerous. There are under 5 reported cases of adenocarcinoma of the RPE arising from these, which is a kind of a malignant version of this. But even those lesions have never been found to develop metastatic behavior. So these really are truly considered very safe. One thing that's very important to know about these is that they will enlarge over time on fundus photography. So the way I always explain this to patients is like if you have a ditch in the sand on the beach, right? Like a lack of sand. The sand at the edge of the ditch at the beach will fall into the ditch over time. And so if you look down on that ditch kind of from a bird's eye view, the ditch is going to appear to enlarge over time. And that's really an exact analogy to these. The retina that lives at the edge of these lesions kind of is living in an environment of atrophy. And so it tends to atrophy over time. You can think about it the same way you do, big aggressive PRP scars you've probably seen, some retina specialists send patients back to you with very aggressive PRP, right? Those scars will enlarge over time because of progressive atrophy. So if you take a picture of one of these in a 5-year-old or a 10-year-old, and then you take another picture of that same patient at 15 years, when they're 15 years old, the lesions are going to appear to grow and can be very scary because it looks like something is, undergoing malignant transformation. But in fact, that is completely expected and is not a reflection of metastatic potential at all. And the only scary thing that can happen with these patients, which probably some of you know, is that if the patient has more than 3 or has lesions bilaterally, then you really do want to pay attention. And the reason you want to pay attention is that there's a rare genetic syndrome in which patients can present with multiple of these in either one or both eyes, particularly if they're, as we like to say, football shaped or with these kind of rounded edges with pointy tips. And that is a condition called Gardner syndrome, or FAP, that occurs as a result of mutation in the APC gene, which is a familial colon cancer syndrome. Obviously, if you see a patient like this is a young kid I saw a few months ago, your head really pops off and go, wow, like this one I got to pay attention to, right? So this is not your run-of-the-mill chirpy. This is the type of patient who you have to really pay attention to. And what we worry about is this particular syndrome. And it's not because the lesions in the eyes in these patients can become cancer. It's actually just a marker, interestingly, of this genetic syndrome in which these patients are essentially at 100% risk of developing colon cancer by their mid-40s. So we send these patients for genetic testing, and if the genetic testing comes back positive, then we send them for gastrointestinal evaluation. So really, the ones you really don't want to miss the most are the ones with multiple, but of course, I'm always happy to evaluate any that are questionable. Sometimes there'll be kind of a gray zone where a patient has two, or they maybe have three, or there's one big one with just a satellite lesion. Oftentimes those turn out to be fine, but it's important to make sure those patients get evaluated. All right. Moving along, it's also important to think about other brown lesions that can be flat. And one thing I see a lot of that I think can cause a lot of panic among primary eye care providers is this lesion. So here's a 12-year-old totally asymptomatic girl who was referred to me for uveal melanoma. Obviously, this brown area has, a really wide base, and so can kind of appear to be, pretty scary. It's like, wow, that looks pretty big. It's like, 10 or 12 disc diameters wide. Very legitimate to feel, afraid of this. When we do OCT through it, you can see that actually the choroid, is not expanded at all. It's actually completely normal choroidal thickness in that area. So there's really no bulk to the lesion. It's not elevated. And on the ultrasound, we can see that it's completely flat. So that's reassuring. So what this is something called congenital ocular melanosis. This is essentially a predisposing risk factor for uveal melanoma. What happens in these patients is that they are born with a segment of their choroid in which the melanocytes, those brown cells that live in the choroid, have a constitutional mutation, a misprint in the DNA in one of two genes, primarily GNA11 and GNAQ. These are genes, G alpha Q subunit mutations, that are initiating mutations for melanocytic tumors. So basically, those genes are abnormal, and it causes those melanocytes to divide and grow a little bit. It stops, it arrests in early childhood at that just flat slate gray looking area, like I showed you in that fundus photo. And for the majority of patients, that's all they have for their entire life. Nothing happens. But in a percentage of these patients, which is thought to be about 1 in 400, so pretty low, but not zero, one of those cells will later undergo a second mutation, which starts driving it into oncogenesis, and they can develop a tumor. So that's why it's important to kind of recognize that this in these patients, so that hey, okay, you're at risk for developing this. We're going to monitor you throughout life. And in the more severe forms of this, it can actually present involving not just the choroid, but can also involve the ciliary body, the iris, if it involves kind of the ciliary body and the anterior choroid, you can actually see it through the sclera, and it can even involve the conjunctiva and the lid, in which case it's called nevus of Voda or oculodermal melanocytosis. And in these cases, the patients are actually at risk of developing melanocytic tumors of the skin as well. So we always like to see these patients just to kind of give them basically a warning that, hey, this is something that could happen to you over the course of your lifetime. We're not super panicky with them. We evaluate them every 1 to 2 years, particularly if they're only children. But it is important to warn them, because in the course of my career, I've seen many a patient who present in their 60s or 70s or 80s with a massive melanoma who had this predisposing lesion, and nobody in their entire life, no eye care provider, ever told them that it was a risk. So it's just kind of a missed opportunity to save a patient's life. So that's kind of an important thing to be aware of. All right, so now we're going to move on to a more common and really, really critical pigmented lesion that we see in the back of the eye, and that's a choroidal nevus. Everyone on this call, I'm sure, has seen patients with these. They are nearly universal if you run a busy eye clinic. They come in many different shapes and sizes and configuration, but the main thing is that they're super duper common. They are thought to be present in about 10% of Caucasian or light-skinned Hispanic patients. And so if you think about it, think about the number of patients in the United States and the number of adults that are being examined, it is an absolutely massive number of nevi. But there are only 2,000 new true uveal melanomas per year in the US on average. So, and when you think about the average lifespan of a patient, which in the United States is pretty long, it's really like a major needle in a haystack problem, right? You got to see many, many, many nevi to figure out, well, gee whiz, which one of these is going to become a melanoma? And that's really one of the many challenges of for all of us, and certainly for people who do what I do. So it's a balance really between over surveillance and under surveillance. You certainly don't want to make one of these patients come back and see you every quarter for the rest of their life if the lesion is very low risk and has almost no chance of turning into cancer. But on the other hand, you certainly don't want to tell them, oh, hey, go off in the sunset, and then you miss a real problem 10 years in the future. So it's a real conundrum. What we really need is an outstanding biomarker, like a test in which we can take fluid from the anterior chamber of the eye or do a blood test and be able to tell the patient, hey, we stuck this in a centrifuge and we did special genetic testing from this fluid or from this blood, and we're able to determine that you will be fine, Mrs. Smith. We never need to see you again. Or, hey, Mrs. Smith, you really need to come back every 6 months for the rest of your life. And unfortunately, that biomarker doesn't exist yet. We're working on it. We're doing all sorts of studies to try to get there, but we're not quite there yet. So traditionally, what do we use as a surrogate in the clinic to kind of judge which of these are worrisome? And those surrogate risk factors are listed here. I'm sure many of you have learned these. Some of these were popularized by Carol and Jerry Shields, who are colleagues of mine who have popularized a lot of these nationally. Actually, Jerry Shields just passed away this week. He was in his late 80s, but definitely a giant in our field. And these are the kind of those factors that people talk about. So subretinal fluid, orange pigment, whether the patient has symptoms, how thick the lesion is, what the base dimension of the lesion is, and whether there are drusen or not. Drusen being a good sign of chronicity and benign behavior. Now, it's important to note that modern research by us and others, this is papers that we've been running for the last couple of years, both on as single institution studies as well as with many of my colleagues around the country, have shown that these lesions, these clinical risk factors that we look at are actually really not reliably tied to metastatic aggression, meaning now that we have all sorts of modern genetics, which I'll talk about shortly, we know that these features do not really match up with them. So they really don't help us predict whether patients are going to develop metastatic melanoma, which is really what we care about. Is this tumor going to grow and get outside the eye and kill the patient? So they're really just surrogates. We have to use them because in the clinic we don't have anything else, but we know that they are really not fully reliable. In truth, most of our recent modern analyses have shown that really the two only truly reliable features are the two related to size, which is base dimension, 10 to 12 millimeters, and height greater than 2 millimeters. The ability to measure the base dimension of these, is pretty universal on the Optos software. You can see here's me, pulling that cursor on the screen, which you're all able to do to kind of measure the base dimension of these. But of course, it's difficult year over year to make sure these measurements are completely reliable and consistent, because when you pull the cursor, it's really hard to know if you're in the exact same spot as you were before. So you have to take these with a little bit of a grain of salt. And so generally speaking, when I lecture eye care providers about when to take care of these patients and when to dish them, this is the general way that I like to think about it. So if the patient has absolutely no risk factors, let's say the lesion is teeny and tiny and in the periphery and totally flat and very small and not thick, and it has a bunch of drusen on it and has absolutely no fluid, no orange pigment, none of those other things, it's very reasonable for you to observe the patient on your own, particularly if you watch the patient for a couple of times in a row and it really doesn't appear to be changing much at all. Once the patient has at least one risk factor, particularly if the patient is older, it looks like it has any thickness to it, the base looks like it's, let's say 3 disc diameters or more. Certainly if it's moving interiorly and it looks like it's going into the ciliary body, even if you don't see any growth, I would recommend that you send it over a test so that we can take a look at it, likely at least every 6 months. And once you see the patient has 2 or more risk factors, so you see some fluid leaking out of it, or it looks vascular, or you see big blobs of orange pigment within it, or any of those other things, or certainly if you've seen it change at all, then I would recommend you send it right over to us in a pretty urgent fashion, because it's really difficult to tell just based on these superficial clinical criteria which of these are more aggressive. And over time, what we've learned is that really the single biggest driver behind understanding the metastatic behavior of these is actually the rate of growth, meaning how much does it change and in what period of time. And one of the only ways to measure that in a very reliable way is with ophthalmic ultrasound, which luckily, I have access to, one of the best ultrasonographers in the country every single day, but obviously is not the kind of thing that most people have available in their everyday practice. So one of the things I like to talk about is, okay, how do you answer patients' questions about these lesions? Because it's so common that you see patients with this, doc, am I going to die from this nevus? And the truth is, for a teeny tiny little flat nevus in the periphery that's flat and never changed. In a patient who's relatively old, they're going to pass away of something else before it ever has time to grow, metastasize. The risk is often as low as 1 in 5,000. Overall, for very small lesions, the figure we've been using for years is about 5%. But I mean, for a patient with a really teeny tiny little flat thing, it's, infinitesimally small. What could I have done to prevent this, doc? Did I do something that made this happen? Did I eat the wrong food, or did I, was it when I did drugs when I was a kid? And the answer is, like almost every cancer in the human body, certainly smoking does seem to be associated with a higher risk of developing this. But other than that, there's really almost nothing that the patient can control. I always joke around with patients, hey, change your race. These are more common in Caucasian people for reasons that are actually not related to sun exposure, just related to genetic changes that run in Northern European lineages. And obviously, that's not something you can change. There are some very rare environmental exposures with this, one of them being extreme exposure to welding without eye protection, because the amount of UV light that is emitted from welding equipment, if you're not wearing any protection, is actually so strong that it goes right through the ciliary body to the back of the eye. So that is certainly one occupational exposure that's been identified, but most other occupational exposures have never been proven. What about if I have a history of skin cancer, right? Patients often have a history of cutaneous melanoma. This is very, very common, and actually, rising rapidly in the population. So if the patient has a history of skin cancer, does that mean that they might have eye cancer or raise their risk of eye cancer? The answer is almost never. There are two identified genetic family syndromes in which patients have a higher risk of developing both cutaneous and uveal melanoma, because of what's called a germline mutation, or a mutation in every cell of their body that they're born in. But that represents an extremely small percentage of our patients. And so in the vast majority of patients, if they have one, it does not raise their risk for the other. And I'll explain a little more why that is in a moment. Did exposure to sunlight cause this? The answer is almost definitely not. As everyone knows, the role of the human lens is to actually block UV light. The majority of UV light is effectively blocked by the lens. And so the tumors that develop in the iris, when we do dissections of them and we do what's called metastatic profiling, they do have a classic UV signature, meaning the DNA is broken in the pattern that we see with cutaneous melanoma. But once you get behind the iris, once you're in the ciliary body or the choroid, those lesions do not show that pattern. And that makes sense, right? Because the sunlight doesn't reach all the way back there. So you can't honestly tell a patient who has nevus at the back of the eye, oh, hey, if you wear sunglasses, this will prevent this from growing, because it's really about the genetics and not about sun exposure. And then if the patient says, well, how long has this been there, doc? I've had eye exams my whole life. How long has it been there? The answer is probably childhood, adolescence. We know from our understanding of embryologic development that these melanocytes migrate forward in childhood, and so they tend to come out during childhood. And because I examine children as part of my practice, I do see nevi in young kids. So the reason that skin melanoma and uveal melanoma are different is really pretty much all explained on this slide. So the melanocytes in the human body derive from the neural crest, which is one of the three major embryologic layers that form all of us as human beings. And those cells migrate and go to different parts of the body and then differentiate and proliferate and mature. And they take on kind of their own new life once they reach their target organ after starting in this like teeny little ball, when we're all just, 20 days old. And melanocytes in particular migrate to all the places listed here on the slide. Most of them go to the skin, but some go to crazy places like the choroid and the ear and the meninges and the bone and even the layering of the heart, and crazy places like the vagina. And once they get to the local environment, they evolve completely genetically in different ways. So essentially, if you develop uveal melanoma 60 years later in your eye, even though it's from that same original melanocyte as the melanocytes in your skin, genetically, it's become completely different. And that's both a blessing and a curse. A blessing because, it's not as common as cutaneous melanoma, but a curse because uveal melanoma does not respond to many of the modern outstanding forms of immunotherapy that have been developed for skin melanoma. And so it's like effectively a completely different disease. So for just the last couple of minutes, I am going to talk a little about uveal melanoma, which is obviously something that most people on the call don't manage routinely, but it's sort of the marquee adult disease that I treat, and certainly of great scientific interest to all of us. This is very rare. As I said, there's only about 2,000 new cases per year in the United States. And we have over the last couple of years become one of the two busiest centers in the country for this disease. It can be very deadly across the board. About 50% of the patients who are diagnosed with this disease do pass away from it. And although for many years they used to say that there was really no improvement in mortality for decades, there have been huge strides in in assessing the prognosis of our patients and developing treatments for metastatic disease. The first FDA-approved treatment for metastatic disease was approved 3 years ago and is in routine use for our patients. And that's a drug called tebentafusp, which is a immunotherapy just for patients with this disease. The disease, as I mentioned, can happen in the iris, in the ciliary body, or in the choroid, and can certainly involve two of those, or even all three of those layers when it's extensive. And so, it presents in all different forms. Here it is when it's at the very back of the eye, in the choroid, right? In this case, involving the entire macula. Here it is when it's involving both the choroid and the ciliary body, kind of bridging that ciliocoroidal gap and actually pushing the entire ora serrata forward because it's so elevated. And then here it is involving both the iris and the ciliary body when it's invading into the anterior chamber. So you can kind of see it in all different ways. In modern treatment of these lesions, we do something called plaque brachytherapy. The construct of this has been going on actually since the 60s and 70s, but our techniques have been extremely modernized and made much more sensitive, much more effective. We use this gold-plated disc, gold because it blocks radiation and is almost like a one-way valve and makes it so that the radiation goes just in one direction. And when you flip this disc over, the disc is filled with these what are called radioactive seeds or beads, and they're almost like the size of a teeny little grain of rice. And we create these very complex plans for each patient in which we maximize the dose of radiation to the tumor, but minimize the exposure to the surrounding structures. We place it on in one surgery, we take it off in a second surgery, and by the time we take it off, the tumor's been exposed to just the right amount of radiation so that the tumor dies. So here's a patient pre-op and the ultrasound pre-op. You can see it has this classic, what we call collar button configuration. It has almost like a little collar button on the top of the lesion, and the retina is detached over it. Here we are intraoperatively placing that disc, and the disc shows up as this very hyperechoic circular shape with these shadows, which are actually from those seeds that are embedded within it. And you can see in this intraoperative ultrasound that it's actually shy. It's not covering that top part of the tumor. So while we're there in the surgery, we rotate it and adjust it, repeat the ultrasound, and make sure it's absolutely perfect. And by doing that, we achieve a close to 98 to 99% rate of controlling these tumors, with this treatment. So it's extremely effective. Here's an intraoperative photo of one of these discs just underneath in a muscle. So a little bloody, a little invasive, but the patients do tremendously well once they get out of the operating room and they recover. And we've published extensively about our results with this procedure with extremely high rates of local tumor control. Once these patients undergo the treatment, the lesions essentially melt away and disappear with a lot of surrounding atrophy. There's that same patient before and after. They don't poof disappear completely, but they essentially turn into like a graveyard of dead cells that are not able to divide and grow anymore and slowly shrink, typically over a period of 3 to 5 years. So if you see a patient who's been treated by us and there's still a bump in the eye, don't panic. That's pretty universal, especially for tumors that start out really large. And one of the amazing benefits we have in our center is that we have a world-renowned ocular pathologist who reviews all of our specimens for our patients and does all sorts of special staining and testing, sometimes in unusual lesions where we actually have to do a biopsy to figure out what the lesion is. We're actually able to get an answer right then and there in the operating room, which is absolutely a huge gift to us. And here's a little quick video of us doing a biopsy of one of these tumors in the operating room, not a super long video, but I'll just give you guys a sense. We often will use either a vitrectomy instrument or a needle. Here's a long, small gauge needle under a high-powered operating microscope in which we're putting this needle into the middle of this very juicy tumor and extracting cells, which we can then send off to our pathologist both for cytology and for genetic testing. The genetic testing is super critical in helping us understand the biology of these tumors for these patients and what their risk of developing metastatic disease is and whether they are going to die from metastatic disease from this tumor. So we've published extensively in our center on the genetics of these tumors. We do cutting edge studies both in our center and in multi-center trials looking at the genetics of these patients. This is a very recent paper we published with 1,600 uveal melanoma patients with my colleagues from around the country in the Journal of Clinical Oncology, which is a very high impact cancer journal, in which we stratified uveal melanoma patients into essentially 4 survival groups that are highly defined, such that for most patients, once we do their surgery and we do their biopsy, we can actually tell them with quite a high degree of accuracy whether we are worried that they are going to develop metastatic disease and that we need to watch them very closely for that, or whether really we've gotten there in time and they're likely going to be safe and have a very good metastatic outcome. Of course, we see all sorts of crazy, crazy stuff in our center, like patients with multiple melanomas and patients with crazy genetic syndromes and all sorts of, really, really, really wild stuff like this picture. But the majority of patients are pretty straightforward for us. As per everything we do at RCTX, we're always trying to move science forward. We do a ton of research, both for treatments for patients who have uveal melanoma, and then also trying to help patients prevent them from developing metastatic disease, plus therapies for metastatic disease, coming up with genetic studies to try to help us develop strategies for understanding which of these nevi are going to transform into melanomas and which aren't, plus treatments for radiation retinopathy, which is the long-term vascular side effect of the radiation treatments that we do. So really from the very beginning of the disease process to the end, we are really attacking every aspect of the patient's care. We work in a very multidisciplinary team on my service. I've got my clinic team, which includes my nurses, my coordinators, my oncology scribe, my clinic manager, my nurses, my coordinators, my ultrasonographer, who's got 25 years of experience working with me, who's absolutely the most skilled in the business. We've got radiation oncologists, we've got melanoma medical oncologists, ophthalmic pathologists, pediatric oncologists, geneticists, and OR staff, and on and on. So I often have the lucky good fortune of being the face of the team, but there are 100 people behind me who hold me up and support me and make all of this outstanding care for our patients possible. So just in terms of an overview, kind of the way I see patterns of referral for these patients, if you're in doubt, always feel free to refer, particularly pediatric patients who can be especially scary, but we're happy to see any patients of any age, 0 to 100. I see patients of all ages. Co-management is really great for benign diseases. Sometimes I'll see a patient with a nevus and say, hey, this one looks really benign. Why don't you see the patient back? And then if you see any changes over time, feel free to send the patient back to me, or, oh, send me the patient back in 3 years, that kind of thing. We have full-time ocular oncology patient care. I've got tremendous coordinators and nurses who answer the phone close to 24/7 if patients have questions. And this is the phone number for my nursing staff for our established patients that they're always welcome to call. You're also welcome to call or email me anytime. Here's my cell phone and my email if you want to jot it down or take a picture of the screen. My preference is that you all not give this number out to patients, but I'm very free sharing it with other eye care professionals and happy for anyone to text me with pictures or questions at any time. And I typically field anywhere from 5 to 25 phone consults a day. So that's kind of part of, what I see as my role in this community. So thank you all so much for your attention. I'm going to skip ahead for the sake of time. I'll skip through our pediatric material, which I wasn't sure if we would get to, just so that we can have time for some more questions if anyone's got any. And thank you guys all for your attention. These are just some of my pediatric patients from over the years, both of whom are teenagers now, which really ages me, and my own teenagers from home.
So, Amy, thanks so much for an amazing talk. I mean, I needed this like before my boards 10 years ago or so. I feel like I feel so ready to sit for them. I'm even like a little anxious, just ready to walk in and take those board tests. But I mean, I just want to echo what you said, and this is just from my personal practice. I mean, your availability is just second to none. I mean, most of the time, sub specialists like yourself are challenging to get in with. And I mean, I can't tell anyone on this, or I can't explain enough to anyone on this call right now just how available you are. I mean, oftentimes by the time I'm able to like walk back and talk to my scribe about a case I'm worried about, they're already scheduled with you like the next day. And so I just thank you for that availability, but I also want to encourage anybody on this call to just reach out because I mean you're so welcoming, you're so open and available to these patients that it's just it's an absolute wonderful resource for anybody who has anything concerning.
Well, thanks, Phil. Appreciate it. I think, honestly, that speaks more to my team than to me. My team is amazing. They are incredibly committed to patient care, incredibly smart, super knowledgeable about diseases that I treat. And I think we built an amazing culture on my team. And so they're, kind of all very, cognizant of how challenging it is for an eye care provider to have a patient with a big tumor in their eye sitting in the chair and understand how, meaningful it is to get that patient in right away. So yeah, everyone should definitely feel welcome to send any patient anytime. And Dr. Harper said on the chat, I didn't realize you saw peds. Yeah, so I do see pediatric patients. I didn't talk a lot about peds on the lecture just because of limited time, but I do see pediatric patients. I run a large pediatric service at Children's Memorial Hermann Hospital, including a huge retinoblastoma service. I tend, when I have only one lecture here, to talk about adults because obviously adult diseases are much more common, but I'm happy to see any pediatric patients that you see in clinic. And Dr. Pickering, we all have nightmares of missing a melanoma. Sure thing, for sure. We get it. Feel free to send anyone you're worried about. All right. Any other questions from the panelists or from the audience? Thanks, Will. Thanks, Dr. Christensen, for tuning in.
Thank you for a great lecture, Dr. Scheffler.
Of course. All right. Well, if anyone has any, private questions they want to ask me, you can feel free to text me or email me. Here, that number again up on the screen. If I should note, if you send me a picture in the smack in the middle of the day and I'm in clinic, I mean, I get back to you immediately, but I'm totally happy to look at any photos you have. I will sometimes say, hey, that's kind of a blurry picture. It's really hard to tell without seeing the patient in person. Cell phone ophthalmology is not a perfect science. So, but I am happy to, review any pictures or any emails anytime. So, feel free to shoot me anything over. And thanks everyone for your attention. Don't forget to get your TOB credits. And I think that wraps it up. Sarah, anything else you want to get out there in terms of housekeeping?
No, thank you, Dr. Scheffler. And for everybody who's on the Zoom call, if you registered and are on this call, we've got your capture for your CE and you're all set. Thank you for joining.
All right. Thanks, everyone. Have a great evening.
Thanks, Amy. Have a great night.